Second white coat. Subscribe and like. Let's learn medicine together.
All right, today we're going to put on our detective hats, but for neurology. We're going to solve a really fascinating clinical puzzle. And this isn't about just memorizing boring facts, no. This is a deep dive into clinical reasoning, where patients' symptoms are actually clues that lead us right to a very specific spot in the brain. Okay, so here's our case. A 69-year-old man suddenly gets weakness on the entire right side of his body. Classic stroke sign, you'd think. But wait, here's the curveball. When the doctor asks him to stick out his tongue, it points to the left. So how is that possible? How can one single event cause weakness on the right and a problem on the left? That paradox, right there, is the mystery we've got to solve. Let's look at the evidence file. We've got that sudden right arm and leg weakness. His speech is slurred, which we call dysarthria, but he understands everything you're saying perfectly. The key clues are the right-sided weakness, that stubborn tongue pointing left, and, this is super important, no sensory problems at all. Every single one of these details matters. So you have this weird combo. Body weak on the right, tongue pointing left. It feels like a contradiction, right? Well, it's not. In fact, that's our single biggest clue. This pattern has a special name in neurology, and once you get it, it's the key to cracking this whole case wide open. This is what we call crossed neurologic findings, and when you see this, it's like a giant neon sign pointing to one specific place, the brainstem. Think about it. One tiny little spot gets hit, and it takes out the limb pathways and a cranial nerve right next to it, and boom, you get symptoms on opposite sides of the body. Let's unpack that. You know how the right side of your body is controlled by the left side of your brain? That's contralateral. So right-sided weakness means the problem is on the left. Easy enough. But here, the tongue thing is ipsilateral, meaning same side. So a left-pointing tongue means the nerve problem is also on the left. See? A single lesion on the left is causing both things. Okay, so think of this as our anatomical map. A stroke causing this kind of weakness could be up in the cortex, or a bit deeper in the internal capsule, or way down in the brainstem, the midbrain, pons, and medulla. We've got to figure out exactly where to drop the pin. And just like that, our first clue helps us cross a major suspect off the list. See, because we have those crossed signs, we can totally rule out the cortex. A stroke up there would make everything weak on the same opposite side. But our weird tongue symptom, that forces us to look deeper. The culprit is definitely hiding somewhere in the brainstem. Okay, so we've narrowed it down to the brainstem. That's good, but it's still a pretty big neighborhood. So now we're going to use our next clue to really zoom in. That tongue, it's not just some random symptom. Oh no, it's a very specific road sign, and it's pointing us exactly where we need to go. So the tongue is all about cranial nerve 12, the hypoglossal nerve. And if we look at our map, if we trace it down the brainstem, where does that nerve's control center live? Yep, only one place, the medulla, right at the bottom. And just like that, we've gone from the whole brain to this one tiny little section. And this brings us to a super important rule of thumb in neurology. When you have this kind of injury, what we call a lower motor neuron lesion, the tongue always points toward the side of the problem. Why? Well, think of it like a tug of war. The healthy side is still pulling strong, but the weak side can't pull back, so the strong side just pushes the tongue over. Our patient's tongue points left, so bingo, the lesion is on the left side of the medulla. Okay, we've got our location, left side of the medulla. Now, let's put it under the microscope. We're going to look at a slice, a cross-section of the medulla to see how one teeny tiny spot can cause all this trauma by hitting two totally different nerve highways. All right, here's that slice in the medulla. See that little cluster of cells near the middle? That's the hypoglossal nucleus. A tiny stroke right there on the left would knock out the nerve signals to the left side of the tongue. And what happens? It points left. First part of the mystery, solved. Now check out its next door neighbor. That big bundle of wires? That's the pyramidal tract. It's basically the main highway for all your motor commands. And those wires are headed down to cross over to the other side of the body. So that same tiny lesion on the left that got the tongue nerve, it also nicks this tract. And the result? Weakness on the opposite side of the body, the right side. I mean, how incredible is that wiring? But hang on a second. Remember that other clue from the patient's file? Sensation was totally normal. Now, this is a really crowded part of the brainstem, so how did the sensory nerves escape? Sometimes what's not there is just as big a clue as what is. Well, the main path for sensation, the medial lemniscus, runs right through here too. But strokes, especially the ones from tiny little blocked arteries, can be laser focused. This one was just big enough to hit the motor stuff, the tongue nucleus and the pyramidal tract, but it was small enough that it missed the sensory fibers right nearby. So the fact that sensation is okay, it actually makes our case even stronger. So there we have it. We followed the clues, we used our anatomy map, and our logic led us right to the spot. We've pinned this thing down with amazing precision. Now it's time to give it its official name. So let's just do a quick recap of our investigation, right? First, the cross signs screamed brainstem. Then, the left-pointing tongue, which is all about cranial nerve 12, told us to look specifically at the medulla. And finally, the right-sided weakness confirmed it had to be in the medial part of that medulla, where the motor highway is. It's a perfect logical chain. And this classic set of symptoms has a name, Medial Medullary Syndrome. You might also hear it called Desjardins syndrome. It's a textbook stroke caused when one of the tiny arteries feeding this very specific spot gets blocked. And what do you get? Weakness on the opposite side, tongue deviation on the same side. Case closed. So, what's the big takeaway from all this? If you ever see a patient with their tongue pointing one way and their arm and leg weak on the other side, your brain should instantly go to one place, the medial medulla. It is honestly one of the coolest, most elegant localizing signs in all of neurology. And it really makes you appreciate why no other spot works. A stroke up in the cortex? Nope, wouldn't give you this crossed pattern. What about a stroke just a little bit over in the lateral medulla? That would give you things like dizziness and sensory issues, but the motor strength would be fine. Only a hit to the medial medulla explains everything we saw. And that really brings us home. A stroke causing right-sided weakness with a left-pointing tongue, you know exactly where that is, the left medial medulla. It's just a beautiful example of how knowing your anatomy lets you read the body like a map. So next time you see symptoms that seem to contradict each other, just remember, they're not contradicting. They're telling you exactly where to look. The only question is, can you read the signs?